Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show, bringing another really great guest for you today, involved in science, technology, medicine, creating a better tomorrow for many people out there. Today on the show, we have the honor of being joined by Dr. Douglas Adler, who is the director of the Center for Advanced Therapeutic Endoscopy at Porter Adventist Hospital in Denver, Colorado. Dr. Adler is also the editor-in-chief of Gastroenterology Endoscopy. Prior to the current role in Colorado, Dr. Adler was a tenured professor of medicine at the University of Utah School of Medicine in Salt Lake City. He was also the head of their GI Fellowship, a program director for several years, and has focused his clinical, educational, and research efforts on the diagnosis and management of patients with a wide range of gastrointestinal cancers, as well as complex gastrointestinal diseases, with an emphasis on therapeutic endoscopy. Dr. Adler is internationally recognized expert on all facets of endoscopic retrograde cholangiopancreatography, which we'll get into that in a bit, endoscopic ultrasound, GI stenting, as well as a variety of other topics, has literally hundreds of scientific publications, I think over 600 now, written multiple book chapters, as well as 9 gastroenterology textbooks. Dr. Adler received his medical degree from Cornell Medical College, then went on to complete his residency in internal medicine at Beth Israel Deaconess Medical Center, Harvard Medical School in Boston, and then completed both a general GI fellowship and therapeutic endoscopy fellowship at the Mayo Clinic, and then he ultimately returned to Beth Israel Medical Center fellowship in endoscopy and ultrasound. A lot to get into today, a lot of really cool topics that we don't normally touch on, but really looking forward to diving in. Dr. Douglas Adler, thank you so much for taking time to come on the show today.
Yeah, thanks so much for having me.
It's great having you. I'm sorry if I screw up some of these large terms today, but bear with me. But
no, you did good. You did good. It's a lot. There's a lot of like acronyms and long words in there.
That's cool.
If you're not used to them, they don't roll off the tongue.
Yeah, that just means it's a cool set of topics. But it's great having you, Doug. Before we get into any of it, though, would love to just pass things over to you for a little bit to just further introduce yourself and just tell us a little bit about your background and why gastroenterology interested you from the very beginning.
Right. So, it's funny because nobody goes to medical school to be a gastroenterologist, like nobody. Because people have no idea what it is. They think poop, they think like, oh my God, why would I want to do that? That sounds terrible. Like, I'll do something more glamorous. And then a couple of years pass, and then people get a very different perspective from being in medicine for a while. And all of a sudden, things that looked really attractive or exciting maybe aren't so great up close, and things that maybe you wouldn't have even considered suddenly get a lot of attention. And for example, of the internal medicine subspecialties, gastroenterology is the hardest one to get into. And for example, when I was the fellowship director at the University of Utah, we had 2 or 3 spots a year, and we stopped opening applications at 400. Like after 400, we didn't bother anymore, basically. And it just shows you that, as time goes on in your career and your training, you see stuff differently. GI it's very, very popular. People want to be gastroenterologists. You get a lot. You get benign and malignant disease, which sounds silly, but it gives you a very, very broad range of things to treat. You get patients from the very young to the very old, and everything in between. And you get a lot of organs that you can work on. Like,
Yep.
I often joke to my cardiology colleagues, like, you have one organ, like, that's it. Like, you just got one organ, but like we get a lot of different organs. And really, really importantly, in the modern world, we do a lot of procedures. Like, I think people don't really understand how much GI has become a procedure-driven specialty. And I do about 2,500 procedures a year, and that's a typical year.
Mm.
And that, what that basically means is that, with the exception of a little bit of clinic, I'm in procedure all day, every day. And I think too, and this is kind of one of the things I think we'll get into as we go, is these procedures have gotten in the last decade far more sophisticated than most of the general public appreciates. And things are changing at a really, really rapid rate. And it's really changing the whole landscape of really medicine and surgery.
And the term you use, and you wrote this very interesting editorial in Gastrointestinal Endoscopy back in July of 2020, entitled "The Transluminal Revolution," which is sort of at the core of how obviously everything you're doing and all those organ systems that you work with in GI potentially impact a lot of other stuff, and we'll be getting there. But before we go into that, if for our audience, because this is a set of topics that we've not really touched on, we're going to have to walk them through a few terms.
Right, totally.
And we're going to start off in general with what a lumen is, sort of defined as this inside space of a tubular structure. And we got a lot of tubes in our bodies, from blood vessels to intestines to airways and all that. And then the principle of what we're talking about when we talk about transluminal, because sort of the little bit of research I did before the show, my colonoscopy, the first one I had last year, that was an endoluminal procedure, so it was inside the tube but not through it. Transluminal, a little different, because you're going across the lumen. Take a little time to sort of educate our audience what we're talking about here.
So, when people think of seeing gastroenterologists, they might think of a joke, guy walks into a proctologist's office, or they know that, like, oh, my mom and dad had colonoscopies, where they put a scope in through the bottom, right, to look for precancerous polyps, drive around, take a look, remove polyps, right? Or a lot of people get reflux, right? Like, I always joke that people under 30, like, when they watch television, they're like, why are there all these commercials for reflux medicines? And then when people are over 30, they're like, oh, because that everybody gets reflux at some point.
Yep.
And for example, a lot of people with reflux will have an upper endoscopy to look at their esophagus and stomach. And again, for a lot of people, that's their interaction with the GI. And it's critical for your listeners to understand that those are the most primitive of procedures. They're the most basic and primitive of procedures, right? They're mostly diagnostic, driving around, looking, taking photos, and maybe removing a polyp or taking a biopsy. Yep. And for example, when you train in GI, you learn those right away. They're the most basic things that people start with. And those procedures are intraluminal, like you were saying, right? Like, your GI tract is hollow, right? It's a set of tubes that sort of interconnect as food passes through you from top to bottom, shall we say. And then everything started to change about 10 to 15 years ago. And it had been known for many, many years, right, that surgeons, right, with incisions, either laparoscopy or laparotomy, right, they could open you up and violate tissue planes, right? They could make holes in organs, right? You can make a hole in the esophagus, a hole in the stomach, hole in the bowel, hole in the gallbladder, hole in the bile duct, and you could connect structures that aren't connected by nature, right? And surgeons have been doing that for forever, right? That's just been a hallmark of what surgeons could do. And for many, many years, only surgeons could do that, right? So if you, for example, if you got really bad pancreatitis, right? Like, you went on a bender, you drank a lot, you got bad pancreatitis, and as a lot of people discover after bad pancreatitis, they develop an inflammatory cyst in their abdomen. And these cysts can be huge, 10, 20, 30 centimeters across. They can be very painful, right? They can make you quite ill. So, classically, the treatment for that is the surgeon would take you to the OR, make a big incision, and they would make a hole in your stomach, and they would make a hole in that cyst, and they would connect those two. And then the cyst would drain into your stomach, and then you had a big incision and a big scar, and you were in the hospital for 10 days, and you were out of your job for a month while you recovered. And then it was discovered, 15, 20 years ago that you could do that with a scope, right? That you could put a scope down through somebody's mouth and do all that from the inside. And then if you did it that way, the patient went home the same day and didn't have a scar, right? And ate dinner at their kitchen table with their family that night, right? Big difference if you're the patient, right? So that was kind of really the first transluminal procedure. The idea that, somebody besides a surgeon could violate these tissue planes and literally make a hole in an organ that didn't have a hole in it. And you have to understand what a revolutionary thought that was, because when you learn to do endoscopy as a gastroenterologist, you are just beaten over the head 1,000 times with don't make a hole, don't make a hole, don't make a hole, don't make a hole. Because if you make a hole, traditionally it meant you had to call the surgeon, the patient had to go to the OR, they had to find the hole, they had to close it. And then with transluminal endoscopy, it flipped that paradigm on its head. And it was, well, let's go ahead and make a hole, but let's do it in a very careful and planned way at the exact place that hole is needed to allow us to access a target and make a bridge between two structures that formerly or previously had not been connected. And just that simple concept, which has been refined over the last 10 to 15 years, has really changed all of GI, and it's very, very rapidly changing surgery. My wife and I recently embarked upon a rewatch of ER, right? The medical drama, soap opera, whatever you want to call it, from the 90s. And, right now we're in the middle of season 7. And a big, big theme on ER when you watch it is they're always running people off to the OR. Like the heroic ER doctors make a diagnosis, and then the surgeon grabs a stretcher and then barrels down the hallway to the elevator to whisk the patient up to the OR. And as I'm rewatching it now, like almost every episode, I say to my wife, that's endoscopy now. That's endoscopy now. That's not surgery anymore. Like it is. In the course of my career, I graduated medical school in 95. But in the course of the time since I graduated, the change has been striking. Like it's impossible to ignore it.
Sure. And yeah, again, for the audience, we're talking now, so minimally invasive, less pain, faster recovery times, low infection risk, obviously, and this principle again of putting together, as you were saying, things that are not normally nature doesn't put them together, and that's sort of this term Lumen opposing, and obviously there's sort of the non-GI stuff that the audience can think about in terms of angioplasty and all that, but we'll focus on GI because this is your specialty. And let's just walk through a couple of these procedures just to educate a little further. And the first one we'll go with is the one I screwed at the beginning, but I want to say it again: ERCP, endoscopic retrograde cholangiopancreatography, which is basically, okay, so we have, I guess, the GI tract, but we got something really bad going on over here in the pancreas. We want to access it. We want to make this opposing lumen situation and drain, or I guess do our surgery through there. Take us to ERCP and a little bit of what that entails.
So ERCP is not a transluminal procedure per se. Okay. So ERCP is a endoscopic retrograde cholangiopancreatography, refers to a set of procedures whereby without surgery, just by putting a scope down through the patient's mouth, right, and getting into their pancreas and bile ducts from the inside, you can perform a very, very wide range of maneuvers that obviate a lot of different surgical procedures. So ERCP is a much older procedure.
Okay.
ERCP is about 50 years old, although it's undergone continuous refinement. So ERCP would not be considered a transluminal procedure, although we do ERCP every single day. It's a different set of procedures because ERCP does not violate tissue planes, right? That's the retrograde part, right?
Okay.
So like the bile, your liver makes bile, right? Like most people walking around think, oh, my stomach digests my food. That's actually not really true, right? Your pancreas, with a little help from bile, and your liver are kind of what digests your food. But your liver makes bile, which is secreted down through a series of ducts to your bowel. Your pancreas makes digestive enzymes and bicarb. And then in ERCP, you use catheters and guide wires and stents and all sorts of devices to go backwards up those ducts into the pancreas and the bile ducts and do all sorts of maneuvers, but those are not transluminal procedures.
Okay.
So, so transluminal procedures really involves like you're violating tissue planes, like you're literally breaking down barriers. You're going through structures that aren't meant to be traversed. Whereas
Okay.
ERCP, you are within the patient's native anatomy the whole time, not violating those tissue planes.
Okay. So thank you for that, because then I'll go to another one, and I think
Sure.
this one is GPOEM,
Right.
and gastroparesis. So this is something my wife has, and
Okay.
she's routinely, so gastric peroral endoscopic myotomy, and again, she's gone to doctors, talked about, okay, we're going to go in, we're going to cut. There might be some Botox also involved, and a lot of things
Right.
happening there. Small incision in the stomach wall. Take us to this one then, because I think
Sure.
this is
So GPOEM, and I feel bad, but GPOEM is also not a transluminal
screwing
procedure.
everything up today. But
That's okay. That's okay. We'll get back to it. But again, it's interesting because the conversation shows all these things that you can have done as an outpatient with a scope instead of a scalpel, right? And then
okay.
before I get to GPOEM, I'll make an interesting point. In my job here in Denver, we train gastroenterology fellows every single day. We have our own advanced fellow. But we also train surgeons. Like surgeons come with us to rotate and they work with us and we give them some endoscopic training. And one of the most common comments that the surgeons say to us is, I didn't know you could do this. And we hear
Okay.
that just as a constant refrain from the surgeons. And they say it with a mix of both awe and concern
Mm.
because the surgeon is thinking, well, if you can do this, does the patient need me?
Mm-hmm.
Right? Because they can see a little bit of the handwriting on the wall, right? Like if you had the option between open or laparoscopic surgery or endoscopy, the patient is going to pick endoscopy almost every single time, right?
Mm-hmm.
Scar, no scar, inpatient, outpatient, right? Sleep in the hospital for a few days, sleep in my own bed that night, right? What is the patient going to pick? Of course, they're going to pick endoscopy. So GPOEM is what they refer to as a third space procedure. So GPOEM is very, very rapidly becoming the dominant treatment for patients with gastroparesis, which unfortunately you say your wife has,
Yeah.
right? So for listeners, your stomach is mostly a reservoir for food, right?
Mm-hmm.
So like a normal person should be able to go to Golden Corral or the buffet in Las Vegas and eat a big meal, like a really big meal. And your stomach should be pretty empty at about the 4 hour mark. Like it's amazing. Like you walk out of the restaurant and you're like, oh my God, I can't eat another bite. And then a few hours later, you're kind of a little peckish. You're like,
Right.
maybe I could eat something. So gastroparesis refers to when the stomach empties poorly, right? And that can occur for a lot of reasons. The classic reason is diabetes, but a lot of people who have surgery on their esophagus or their stomach can wind up with gastroparesis. It can also be caused by marijuana. And I live, for example, here in Colorado, which is the marijuana capital of the world,
Mm-hmm.
and other things. So people with gastroparesis, now again, I don't know how serious your wife's is, but people with gastroparesis, they often are profoundly impaired in their ability to eat because their stomach doesn't empty. So if their stomach doesn't empty, the food sits there, they get nauseous, they have pain, they feel bloated, they
Yep.
very often vomit multiple times a week or
Yeah.
more. And gastroparesis has proved to be an extremely vexing problem to treat, like for decades. You can put people on gastroparesis diets, right? Very, very small meals, a lot of liquids, and those diets are really effective, but people don't like them because that's not how our society and our culture is. And you want to chew your food, you don't want to drink all your meals.
Yeah.
You can put people on medications, and we've published a fair bit on this. Medications for gastroparesis work, and I assume your wife has tried them at some point. But the problem is they have a serious risk of side effects, and
Yeah.
those side effects can be debilitating, and some of the most feared side effects can persist even after the patient stops the drug. Um, so people often have this sort of love-hate, push-pull relationship with drugs in gastroparesis.
Yeah.
And then at the end of your stomach, you have a valve, right? It's plumbing. You have a muscular ring called the pylorus that opens and closes all day long. And in a perfect world, when the stomach contracts, the valve opens and lets the food leave the stomach and enter into the small bowel where digestion really occurs. And a lot of people with gastroparesis, they have a valve that doesn't work properly. And when the stomach contracts, the valve paradoxically shuts or it doesn't open very well. So in the past, people said, well, let's open up the pylorus. And you could either do that with Botox, right? Just like you can get Botox in your forehead to treat wrinkles. You can get Botox into your pylorus to paralyze that muscle so it stays open. So it doesn't make your stomach contract anymore, but it makes the contractions you have much more effective because the stomach isn't working
Mm-hmm.
against a closed valve. And then surgeons would often take the patient to the OR and cut the pylorus. It's either called a pyloromyotomy or a pyloroplasty, depending on the
Mm-hmm.
operation. But it's the same idea. Like, let's just cut that pylorus so that it's open all the time to promote better gastric emptying. And it's very effective. And then about a decade or so ago, the GPOEM was introduced. And the GPOEM is basically the way to cut the pylorus without going to surgery. So we do these constantly in my practice. And we put a scope down through the patient's mouth. We make an incision in the stomach and we excavate or tunnel our way through all the layers of the stomach wall. And
Mm-hmm.
then we expose that pylorus muscle. And then we cut it on the inside. And then we close the incision we made in the patient's stomach, pull the scope out. The whole thing goes very quick, and the patients go home the same day. So no scar on their abdomen, no inpatient stay. Patients go home the same day. It takes time to recover from that, but I mean, the change that it produces in the patient's symptoms is dramatic. Like, I mean, I've had people in my clinic crying, like I haven't been able to eat in years. I got off of my feeding tube. I'm no longer fed by an IV. The husband will be on with the patient saying, Shade a sandwich. I haven't seen her eat a sandwich since 1997. Like, I mean, the effect that these procedures can have on people with gastroparesis is really, really striking.
Mm-hmm.
But, the GPOEM and transluminal procedures, they share something in common is they violate, right?
Right.
We go places that we're not supposed to go and that formerly only surgeons went, right? And the GPOEM is what they call a third space procedure. And there's a bunch of these third space procedures now. But again, it's the same idea. Like, we're doing now in GI in endoscopy what the surgeons used to do. And again, for
Right.
surgeons who are listening, I don't want surgeons to feel like I'm going after them. Like, I'm just saying the truth. Like,
Yeah.
this is just the reality.
No. I appreciate you taking us through this. And I'm sorry I'm 0 for 2 on these, but
No.
so here's the third one, and this comes out of your the
Okay.
Transluminal Revolution paper. So, and I'm going to say this one too: endoscopic ultrasound guided Choledochoduodenostomy using an electrocautery enhanced local anesthetic minimally invasive surgery procedure. I'm assuming that this one's transluminal.
Right. So this is
Okay,
so this is a good example, right? No,
cool.
you're okay. I mean, it's just tough. It's a lot of jargon. Sometimes like when you're in medicine, like it's easy to forget. You're basically speaking another language.
Yeah.
Um, so a classic problem, like an unbelievably common problem, is somebody gets cholecystitis, right? Their gallbladder goes sour,
Yep.
right? And you've all met, everybody listening knows somebody, or maybe they've had their gallbladder removed, right?
Mm-hmm.
So if you're a healthy person, the best treatment for you is to go to the OR and have your gallbladder removed. So there's one for the surgeons, right? I'm still on the surgeons team, right? If you're a good surgical candidate and your gallbladder has stones or is infected or both, right? The best treatment for you is to go to the OR and have some bright young surgeon take out your gallbladder. And then that problem is gone forever, right? No gallbladder, no cholecystitis. But it turns out that in real life, about 20 or 30% of people who get cholecystitis, they are not surgical candidates,
Mm.
right? They have malignancy, right? And for example, people with cancer have a much higher risk of getting cholecystitis, especially certain cancers. Or they have heart failure, right? And they're
Mm-hmm.
being seen by a cardiologist for heart failure. Or probably the most common one is they have cirrhosis, right?
Yep.
People with cirrhosis are extremely high operative risk. So the surgeons in those patients will often leave skid marks running away, right? Because they know that heart failure, malignancy, cirrhosis, that person's not going to tolerate surgery. They're not going to do well. Their risk of post-operative mortality is high, right? So the surgeon wants no part of that. So, up until just a few years ago, those patients were offered what's called a percutaneous drain, right? Where
Mm-hmm.
a radiologist would make a hole in their side and they would put a tube from the outside world through their skin, through the muscle of their abdominal wall, and into the gallbladder. And then you could drain the infection to the outside world. And the person would have a tube sticking out of their side that connected to a bag.
Mm-hmm.
So a tube like that gives and a tube like that takes. So the
Sure.
big advantage of a tube like that is it works. Like your gallbladder infection will go away and your symptoms will get better.
Mm-hmm.
The downside is you have a tube sticking out of your side connecting to a bag. And there's about a 40% chance that that tube will never come out for the rest of your life.
Mm.
Right. So you could see why all of a sudden, when people are in a crisis, they're like, put the tube in, put the tube in. And then when the crisis is over, every other thought all day long is take the tube out, take the tube out, take the tube out. And, these tubes, it's hard to dress, it's hard to bathe, they leak. You may look down and there's bile all over your clothing, right?
Mm.
It's hard. You can't roll over in bed. It's hard. You know what I'm saying? You got a tube sticking out of your side,
Right.
right? And good
Right.
luck being intimate, right? With a tube sticking out of your side that's connected to a bag. So the gallbladder was not the first, but one of the first transluminal targets. So people
Right.
said, well, if all we really need to do is drain the gallbladder to put out the fire, let's do it internally.
Mm-hmm.
So we have these special stents. Stents are flexible metal mesh cylinders. And we have these special stents that we use where under ultrasound guidance from the inside of the patient's body.
Mm-hmm.
Like imagine a scope that doesn't just have a light and a camera on it, but it also has an ultrasound. So we do an ultrasound from inside the person, right? When people think of an ultrasound, they think of like jelly on their belly and somebody looking at a baby. That's an external transabdominal ultrasound. This is an internal ultrasound, much higher resolution. And then we would either from the stomach or the bowel, we'd look for a window, and a window is a clear line of sight between the stomach or the bowel and the gallbladder. And then when we got it, we would make a hole in the stomach or the small bowel, make a hole in the gallbladder, and connect those two with the stent. And then the gallbladder can drain internally. All that infected, dirty stuff in the gallbladder drains into the patient's gut, where it's just absorbed, and then they never need surgery ever. And that stent can be left in permanently. No tube, no stitches, no scars, often done, often done in 15 minutes or less, and the patient can go home in very, very short order, right? So that's a really, really good example of that. Like that's a true transluminal procedure that saves the patient a tube that maybe never comes out. And if it, even if it does come out, it's in for weeks, if not months, before it's removed, right? So the nice thing about the endoscopic approach is that stent can stay in forever. And then the patient's risk of getting gallbladder trouble in the future becomes drastically lower, right? Because they always have that stent in place to protect them.
Got it.
It's interesting. Like, it's really, really exciting. I remember over a decade ago when the very first time I drained a gallbladder transluminally, and, part of my brain was like, you've been told don't do this. You've been told don't do this. You've been told don't do this your whole life. But there was the gallbladder, just, big as life right in front of me. And I was like, let's do it. I remember when we did it, we were so excited. Like, we all felt like we were Neil Armstrong and Buzz Aldrin, landing on the moon. Like, it was such a big deal.
Right.
And now they're routine cases. I mean, they literally get scheduled for 30 minutes and you're done in 15.
That's an awesome example. And I'm glad, we got that one, and it can explain to the audience, again, the comparison there, right. Not just in the speed and the effectiveness here, but quality of life issues, as you were pointing out. So that's perfect.
I think the trouble for a lot of patients is that a lot of surgeons may not know about all this stuff, right? And for example, like, you may roll into the ER, like, let's say, God forbid, you have cirrhosis, which is really common. And you roll into the ER and the surgeon takes a look at you and says, oh, not a surgical candidate. And the ER doc or the surgeon or both, they don't know about transluminal procedures. And then the only thing the patient gets told a lot of the time, unfortunately, is, oh, you have to have this tube. Right. And then they get the tube, and then, that they can't get the tube out, because whenever somebody tries to take the tube out, they get sick again, or their symptoms recur. And then, sometimes those people find their way to us months or years later. They're miserable. And then we have to do what's referred to as a rescue, which is try to drain the gallbladder, even though there's a tube in it and it's decompressed, so that they can get the tube out. But part of the problem is, the awareness of a lot of these procedures is still growing. And, it's hard for humans to change their thinking. If you're an ER doc or a surgeon, and for the last 4 decades, you've been telling people who weren't surgical candidates that this tube is your only option, it's hard to change your thinking. Right. So part of my job is I run all around the country speaking on these procedures to non-GIs, right? To surgeons and internists and other types of doctors, to let them know. And a lot of times they are absolutely shocked to know that these things exist. And I remember over a decade ago, I once presented to a large group of surgeons about draining pseudocysts, like large pancreatic fluid collections. And I knew I was walking into the lion's den, because, this is kind of me saying, well, we're going to take this procedure from you. Right. And again, people are people, and their salary is linked to their procedures and their volume and all these things. And it was a very, very hostile reception, and again, I don't blame them. They viewed me as an interloper. But, a decade has now passed, and I think that now a lot of surgeons are really coming around. They recognize the value of these procedures to the patients, and it saves them from doing a procedure that, in all fairness, a lot of them didn't particularly even like doing. Right. So, their initial reaction has changed over time. And I think as young surgeons are coming up and they're seeing all these things happen, like when this young surgeons are in training, they're working cheek to jowl with their GI colleagues and they're hearing about and seeing all these procedures. I think the new generation is coming up just aware of these things and they don't feel nearly as threatened. But I will never forget that first time I gave grand rounds to a group of very senior surgeons, and it was not a warm welcome. Even though we had really good data to back us up. And again, I don't blame them. If somebody, I imagine that was scary for a lot of them because they viewed it through a very personal lens.
Mm-hmm. Let's yeah, I mean, so it's awesome. I mean, you're obviously you're out there, you're teaching the world. As I mentioned, you're editor-in-chief of Endoscopy, and you're publishing on these amazing concepts. But let's go a little further because clearly you see all the innovation in research that's happening, and I thought we could talk about some of that. And again, I'll initially focus on the fact that in your world. We could just drill down on cancer for a moment. I mean, you deal with a lot of nasty stuff in terms of colorectal cancer and liver cancer, and really, really nasty when we get to the pancreatic. And clearly, we on our show we focus a lot on everything from targeted gene therapies to the smart stents and bioengineering and everything in between. I mean, where if we go to the horizon a little bit, look at a couple of years. I mean, where is some of this headed? What excites you in terms? Obviously, you're talking about what we're taking out and draining and all that, but what about what we're putting in? Some of the novel technologies. Take us a little in that direction.
So there's an enormous amount of funding being put into new endoscopic technologies, both from industry, right, foundation grants. I mean, endoscopy has gone from basically a cottage industry in the US to a global multi-billion-dollar juggernaut. So it's been amazing for me to see how much endoscopy has changed and where it's headed. So I think one of the biggest areas right now is so-called endobariatrics, right? Because there's so much focus on obesity, right? So in the past, right, if you wanted to lose weight permanently and quickly, you had weight loss surgery, either a Roux-en-Y gastric bypass, which was the most common surgery that was replaced by the so-called sleeve gastrectomy, and there were other weight loss procedures. But now we are starting to see the rise of endoscopic weight loss procedures. And this is something that's been worked on for a long time, but is now really starting to come to fruition. And one of the most common weight loss surgeries is referred to as a gastric sleeve. And that's where the surgeon essentially removes part of the stomach to make the stomach more tubular shaped so that the stomach can hold much less volume. Like if you have less stomach, you can eat less de facto, right? You can't go to the buffet, right, at Golden Corral, to make my second Golden Corral reference of this podcast, because you just physically can't hold that much food, right? You just can't.
Just gotta tell you, we love Golden Corral, but go ahead.
Everybody loves Golden Corral. They have a chocolate fountain. Who doesn't love Golden Corral?
Exactly. Sorry to interrupt.
No, it's okay. But so the sleeve a few years ago replaced the Roux as the most popular weight loss surgery, but now a sleeve can be done with a scope. So it's called ESG, endoscopic sleeve gastroplasty. So you can basically create, without a scalpel, without an incision, you can create a sleeve in the patient's stomach, and they can achieve, for all intents and purposes, comparable weight loss to people who had the big operation. So that is being done in the US by a relatively small number of people, although the people who do it find that the desire for patients to do it is enormous. Because again, if you give people two options, surgery, incision, stitches, or endoscopy, no incision, no stitches, right? People are moving and moving more and more towards endoscopic treatments.
Mm-hmm.
Now, the catch to all of this is GLP-1 drugs,
Yep.
right? So, and I will tell you here, and I've tweeted about this a little bit, in Denver, without a doubt, bariatric or weight loss surgery volumes have fallen sharply. And many surgeons have commented on this to me because people are taking Ozempic, Wegovy, drugs like it, and they are losing profound amount of weight. So again, whereas almost everybody will pick endoscopy over surgery, almost everybody will pick a pill or an injection over any procedure.
Sure.
So as endoscopic weight loss procedures, with the ESG being the most notable one, are kind of coming to the forefront, it's happening at a time when GLP-1s are undergoing widespread adoption.
Right.
So it'll be interesting to see, who wins. It's almost like an arms race, like who's going to win that race, who's going to come out on top. I did a podcast on my own podcast. I did an episode about this about a year or two ago, and there's very divergent opinions
Mm-hmm.
about whether endoscopy or surgery or GLP-1 drugs are going to come out on top in the next 10 years or so. But I mean, obviously, the US is still facing an obesity epidemic, and and to make a terrible pun, there is an enormous hunger for weight loss therapies that are effective.
Right.
So, but I think that endobariatrics, there's been a couple of procedures and devices that have been around for a while, but I think the endoscopic sleeve is without a doubt the leading one.
Right. Well, while we're on the, I'm glad you brought GLP-1. I was going to bring that up in a little bit, but I might as well do it now because you have it. I mean, you had a paper from a couple months ago on ultimately how GLP-1s potentially were impacting bowel prep, and you didn't find any problem there. But it got me thinking about sort of, I mean, GLP-1 for all the trillions that they're generating, a lot of the problems in terms of the pancreatitis and enzymes and gallbladder issues and all that obviously fall into your domain there. And
Right.
I was just how do you think broadly about GL? I mean, putting aside weight loss and sort of the comparisons with the sleeves and all that, how are GLP-1s otherwise impacting your world in this context? Because it seems like this comes full circle. If there are bigger problems than we think at this point in your domain, that
Right.
you're going to have a whole suite of patients probably with problems.
Yeah, no, it's true. I mean, I will tell you that I've been very impressed by them. And, full disclosure, I don't work with any of I don't consult on GLP-1 drugs or anything like that, but I've been very impressed by them. I mean, all medications have the potentials for side effects.
Sure.
And for example, GLPs can cause gastroparesis, right? That's one of the
Of course.
ways that they work is they slow
Yep.
your stomach down and you feel full. And for example, a very good friend of mine has lost about 60 pounds on Ozempic.
Nice.
And he says to me that he just feels full all the time. Like he said that that's part of how it works for him. Like he has very, very little appetite. He's just full all the time. Like he eats a little bit and he's like, oh, I can't eat another bite. Because his stomach, like the GLP agent, has affected his gastric contractions. Um, but that having been said, I mean, I think we see a lot more success stories than adverse events. And, pharmaceutical companies are full of smart people and they are working and trying to generate more tailored drugs that perhaps give you the same weight loss benefit with fewer or less severe side effects. So we went through some sort of portal, I think, in the last 36 months where these drugs went from something that were mostly used for diabetes, or you would occasionally hear a rumble that celebrities were taking them to lose weight. And now it's unbelievably common,
Mm-hmm.
these drugs, and the access to them is like the barriers to access, shall we say, have fallen sharply.
Mm-hmm.
You can get these from online pharmacies. Your PCPs are much more comfortable prescribing them. I've been to shopping malls. I'm not making this up. This sounds crazy, but it's true. I've been to shopping malls where they have like a nurse practitioner, sitting in a little tiny kiosk, and you can walk up, have a 10-minute visit with them, and walk out with your prescription for your GLP. So I imagine that their use is only going to go up. But I mean, we are seeing a lot of people who have lost 10, 20, 25% of their body mass on these drugs. That's a lot of weight loss. And you tend to hear about the ones that are having troubles, but a lot of them are tolerating them just fine. I mean, I think it's changing everything. It's one of the biggest advances in medicine, or the biggest sea changes that I've seen in the 30 years I've been a doctor.
Coming back from to transluminal work, and let's say shift from sort of biotech to tech bio. You have several papers in the last couple of years on applications of artificial intelligence and machine learning for predicting colorectal cancers, and AI and colonoscopies and all sorts of stuff like that. And I've hosted some of the Medtronic folks on the show that are, I guess, developing some of the devices that you're using for
Right.
this stuff. But talk a little bit about this, and a little bit about how some of these tech bio tools are impacting your world, but also how they potentially can enhance what you're thinking about in terms of the transluminal revolution.
Yeah, so AI has hit GI pretty hard, meaning in a good way.
Sure.
Endoscopy is very well suited to AI applications because it generates, electronic image that's digital, that a computer can analyze. And Medtronic a couple of years ago came out with the first commercially available AI application, GI Genius, I believe it's called, where when the doctor is doing a colonoscopy, right, looking for polyps, the AI is looking over their shoulder. And
Mm-hmm.
the AI is also doing a separate independent evaluation of the patient. And on the Medtronic device, it sort of highlights a polyp. And again, the odds are pretty high that the doc already saw that polyp, right, and was going to take it out anyway, but it serves as sort of a backstop.
Mm-hmm.
Like,
Mm-hmm.
hey, just to make sure you saw this, here is a polyp, or, you know, don't forget about this lesion. And to date, GI Genius is pretty much the only commercially available AI application, but there is enormous development in this space. I mean, vast sums of money are being put into AI applications in endoscopy, and at Gastrointestinal Endoscopy, the journal I edit. um, it is very, very common for us to get papers on new AI applications,
Mm-hmm.
right? And for example, like, to bring it back to colonoscopy, like when you get a screening colonoscopy to make sure you don't have a polyp or cancer, right? You would ideally like for the physician to have looked at the entire surface area of the colon. But in real life, we know it's really, really hard to see the entire surface area of the colon. It's not a PVC pipe. It's a complex three-dimensional shape with folds and turns and twists. So, you really can't see everything per se, but you want to see as much as possible. And like, for example, one of the more interesting AI applications is the computer tracks the surface area that you've seen.
Mm-hmm.
And the computer can say, hey, you saw 92% of the predicted surface area of this colon. Great job. Or the computer might say, hey, you only saw 68%. Like, you went really fast through this segment, or you didn't get a good look here. Go back and look again.
Right.
So
Right.
that, I think something like that to me is really helpful. And then another area, a very, very common problem in ERCP, to bring it back to that,
Sure.
is people get strictures in their bile duct, and it can be very, very challenging to decide, is a stricture benign or is a stricture malignant, right? Is
Mm-hmm.
this going to be a headache that will cause problems but will eventually go away, or is this going to kill you? Because most malignant strictures in the bile duct are lethal. But unfortunately, they can look very, very similar. And another AI application is to put a miniature scope inside the first scope and put it in the bile duct I mean, a scope thinner than a pencil, and get HD images of the inside of that patient's bile duct and look at that stricture and
Hmm.
have the AI analyze it and compare it to hundreds or thousands of historical controls and say, hey, this looks more like a benign stricture, or hey, human, this looks more like a malignant stricture.
Got it.
So, you can almost kind of think of it as, I often think of things in sort of aviation terms, but like the AI is going to be your wingman,
Hmm.
right? Or
Hmm.
or your co-pilot, right? Sort of looking out the windshield of the plane with you and making sure that everything is copacetic. So,
Hmm.
like the two examples I just gave, surface area or polyp identification in colonoscopy, or stricture evaluation in ERCP, the doc is still making their own independent judgments and decisions, but the AI is there again to sort of, backstop them and provide additional information or insight or thoughts into what the doc is seeing right there. So
Hmm.
I suspect, I mean, now it's, what is it? It's the end of 2025. I suspect in the next 36 to 48 months, we have several other commercially available AI programs integrated into procedures. And I don't think most people are afraid of that. I think most people would welcome that. And if you were the patient, you'd probably feel good knowing that there was another set of eyes, whether they're human or virtual, watching the procedure so that everything's going smooth.
Absolutely, and I'm the last person afraid that Skynet's going to turn on and
Right,
and do
right,
something bad to me during my procedure. But no, I'm
right.
all
When
for it, and
Skynet
then
starts driving the scopes, the GI docs will get a little nervous.
we'll have bigger problems by then. But it's not,
It's funny
um,
because in the movies, I was just thinking about this weekend. Uh, like AI in the movies is always malevolent.
I
Like
know,
AI is never friendly or helpful in the movies. Like going all the way back to HAL 9000 and 2001 to
I
Terminator
know.
2, like AI is always malevolent.
Yeah, so are the zombies too, but that's another story.
Yeah, I was gonna
But
say I'm not sure that we're gonna be seeing movies where the zombies are friendly.
why not? But no, coming back to GI, and
Good.
I so appreciate the time you're spending with us, Doug, because there's a lot of really great things that you're talking about here and things you've been involved in. There's a couple of themes I want to touch on while we have you today, and I'll just preface this with the fact that as we're speaking, one of the main topics in the news is how former President Joe Biden is fighting late stage prostate
Right.
cancer. And, aside from the therapeutics that they're talking about in the news, one of the main things they're bringing up is the fact that we stopped doing the PSA testing in the country at a certain age. And this happened to my father-in-law, where he wasn't diagnosed till 87, and they stopped doing PSA on him years before. You have a really interesting article where you analyze 15 years of data from 1998 to 2013, and you published this in October 2020 on sort of the adverse effects in octogenarians and colonoscopy. And I'm kind of interested because aging and longevity is a kind of a hot topic for us on the show. Clearly, an octogenarian of yesteryear is going to be a little different than the maybe the younger octogenarian of today. But love to just get your perspective on what's happening in sort of that domain, how you think of the elderly, how you think of some of these procedures, and what whether the transluminal work or other things that you're focusing on can more properly impact sort of this health span theme that we hear a lot about nowadays.
Yeah, so it's a really good question. I'm glad you asked it. I saw on CBS News like last night before I went to bed that Biden was starting radiation
Yeah,
therapy. So, I mean, he's obviously in the thick of it.
yeah,
I think that we're much more aggressive in older individuals now than we used to be. And I think that there used to be, like, for example, when I was in medical school, there was a like, well, let's not push our luck. This person's too old. You know, we've done all we can. We'll let nature take its course. And then as all of these new procedures are developed, one of the things that always gets looked at is as extremes of ages. Can you do the procedure on a child? Can you do
right.
the procedure on somebody greater than 70, greater than 80, greater than 90? And almost always it turns out that endoscopic procedures are well tolerated among older individuals. And our threshold to do fairly aggressive work in older patients has fallen quite sharply. And for example, we mentioned ERCP a couple times in the podcast. ERCP was one of the first pretty aggressive and interventional high-risk procedures that was really studied in older individuals. And the study you cite was one of the larger analyses on that. And it turned out that it actually was pretty darn safe. And you were often in the past trying to convince your anesthesiologist, because the patients are sedated when we do this, like, hey, you got to put this guy under. We need to do this. And the anesthesiologist would classically say, oh, they're too old, they're too old. And now we can show data.
Mhm.
Actually, they're not too old. And for example, I've often told the story that the oldest person I've ever done an ERCP on was 106. And that person lived
Wow.
3 more years after that procedure.
Hmm.
So, like, again, that's an extreme case, but now we don't even blink at doing a lot of this work in people in their 80s. I think when people are in their 90s, then there's sometimes more of a conversation about, risks and benefits and goals. But that having been said, I mean, we've done a lot of very aggressive work in 90-year-olds who are cognitively intact and good health otherwise. I mean, that's how you get to be 90. You have a good heart and good lungs and good kidneys.
Yep.
So I think that, as we get more and more experience, we're always going to be exploring these extremes of age, both very old and very young. So,
Mhm.
like, if you look through the GI literature on almost any procedure, at some point analyses will be done on the extremes of age, because not everybody's a healthy 30-year-old.
Sure. Yep. No, I appreciate that. And one other theme, Doug, I have to ask about, we started off the discussion about, why GI and,
Sure.
people thinking it's all about poop and stuff like that. But interestingly, you
Yeah, I
also have,
haven't mentioned poop once this whole talk.
well, I'm going to, because you have a couple of papers on fecal microbiota transplantation, and this is kind of like um, a new concept, but not new. I mean, it's been around, but it's we see more of it, let's say, in the literature than we have before. And at the end of the day, we're taking poop from one person and putting it in another, and it's a little messy and heterogeneous and live therapy, but seems to be having some interesting impact in some of these therapeutic areas. And just again, with your expertise and having you today, I'd love to get sort of your lay of the land of where we are with this new old
Right.
therapeutic option.
So again, I'm not an expert at FMT, as we call it. Fecal microbiota transplant is the idea that you could transplant the bacterial contents of one person to another. So it's interesting. The idea, I'm not making this up, the idea behind FMT is over 2,000 years old. And an ancient people in the ancient world discovered that if an animal got sick, especially if the animal got diarrhea, you could feed the animal stool from another healthy animal, and they would often recover.
Yeah.
So, like, literally, like 2,000 years ago, somebody in Athens knew to do that. Um, and FMT in the US is very, very widely used to treat Clostridium difficile, or Clostridioides as it's called now. It's been renamed, right? Or C. diff for slang, right? So C.
Okay.
diff is unfortunately a very, very common and very virulent pathogen that can give people profound diarrhea and colitis, and can sometimes be fatal or result
Mm-hmm.
in people having to have their colon removed.
Yep.
And the first line therapy for C. diff is antibiotics, but a very high percentage of patients fail. And FMT has really proven to be a transformative and life-saving technology for these patients. And the technology has evolved from sort of like a homebrew kitchen science, to uh, industrially made stool samples that were instilled by colonoscopy, and now it's pills. It's poop pills. Just to get the word poop on the podcast one
Nice.
more time. Poop pills, where the patient swallows 20 or 30 capsules of pre-made poop pills. And I mean, I mean, FMT almost always cures resistant C. diff. I mean, some of these people they're profoundly ill, they're on death's door, and then they get their fecal transplant by whatever route they get it. And I mean, the turnaround is so fast. It's really, really striking. So FMT is being looked at for other diseases. So far, it's only primarily being used for C. diff infection,
Hmm.
And listeners of the podcast, if you ask around, I guarantee you somebody you know or somebody in your family has had C. diff. It's a big deal and it's unfortunately very common.
Hmm.
Um, and a lot more people have had FMT than you think, but they're looking at it for inflammatory bowel disease, other, irritable bowel syndrome, a variety of other GI illnesses. But I have to sort of stress that for those indications, it is experimental only. So I believe right now it is only FDA approved for C. diff infection, but people are looking at it for all sorts of other things because, again, we're just now discovering the incredible role that the microbiome plays in not just GI health, but all sorts of aspects of human health.
Yeah. 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 That's where I was going with that. And yeah,
Yeah.
again, it's I just wanted to point out again to the audience the diversity of science and innovation that you focus on, and here we have something extremely old, but it's making its way in
Yeah.
the
Yeah.
21st century world
Yeah.
of advanced GI tech. So I mean,
I love my job. Like I
yeah,
love being
that's
a doctor. I love being a gastroenterologist. I think I would have rather been an astronaut, just as a lot fewer seats, a lot fewer slots. But if I can't be an astronaut, like I'm really, really happy being a
yeah.
gastroenterologist.
Well, let's go there because when one puts Douglas Adler into Amazon, aside from books like the Little GI Book and Self-Expanding Stents and GI Endoscopy
Right.
and all sorts of other texts, we run into a book entitled From the Earth to the Moon, a mini-series companion. You think
Right.
you read it all and know everything about the moon flights? Think again. Now you mentioned Buzz Aldrin and Neil Armstrong at the beginning and how you felt like that when you were doing the first transluminal procedures. But take us into your interest in all things space and
Sure.
anything. I mean, I talk about Apollo 11 and all things on that front, but anything interesting space wise? I mean, we do a lot on
Yeah.
space medicine and talk to the space station folks about all the cool. I mean, I'm sure our GI system gets pretty screwed up once we're floating around in zero gravity for a while, but I don't know if you're thinking about anything in terms of that as well, but please.
Yeah. So I like a lot of people, I was captivated by NASA and human space flight as a child. And I was very, very lucky. When I was a medical resident, my program director, against all odds and my initial suspicions, gave me leave to leave my residency for a little while and go live at the Johnson Space Center in Houston. And I took some courses in aerospace medicine, and
Nice.
I did research with a woman named Locke Pucha, who unfortunately has since passed away.
Mm.
It was a way for me to kind of nurture my interest in aerospace and aerospace medicine. I've learned to fly, and I've written about 80 or 90 magazine articles now on aerospace. A lot on aviation, a lot on crewed and uncrewed space flight. So, like I write a lot of medical stuff, but it's been very rewarding for me to have a non-medical outlet because most of the space stuff I write about has nothing to do with medicine.
Yeah.
So it's your brain is meant to be able to think about lots of things at the same time. So my brain is 80% GI and 20% interstellar travel or retro rockets or something like that. So it's been very, very rewarding to write all this stuff. And a few years ago, my buddy Peter Bernstein and I did a podcast on the HBO miniseries From the Earth to the Moon. And
Hmm.
then he turned that into a book that actually sold very well. So that was really, really nice to see. So, but it just shows you like you can do anything if you just kind of put your mind to it. I just started writing to magazines and websites and saying, hey, could I write an article about, you know, the Gemini 6 mission of 1965, or could I write an article about the Skylab 2 mission of 1974? And, I got a lot of yeses, so I just kind of kept going. So I think right now I have 6 aerospace articles that are in press that I'm just waiting for them to come out in various magazines and websites. So I mean, again, it just shows you can kind of do anything. I wish I could have been an astronaut. I don't know. I might be a little too old for that now, although John Glenn flew I believe in his 70s. So I don't know. Maybe I'll get my chance on maybe Jeff Bezos will let me fly on a Blue Origin rocket. If Jeff Bezos, if you're listening, I'd love to fly on Blue Origin.
Well, I mean, no, it's again, we hear so much about what goes wrong with the eyes and the heart and everything
Oh
once
yeah.
we're up there. And you got to imagine, but whether it's the GI, luminal spaces, or the microbiota and all that stuff, I think there's a lot of research for you to do up there at the
Oh
same
yeah.
time.
I would
So
love to.
hopefully,
Space medicine's really, really interesting. And,
yeah,
you know, and, hopefully in 2026, Artemis will send people around the moon. And, as we move back to more long duration flights, space medicine's always going to be important. The ISS
yeah,
and Mir taught us that, the importance of space medicine on long duration missions.
yeah, yeah. Doug, what else is coming up that we should know about as we get to the end of 2025 into 2026? Any other public facing stuff while we have you today? Conferences, talks, other initiatives that I missed? Please.
Well, I would just say that, the journals are where everything happens, right? This is something that I think a lot of patients don't really understand. Patients think in terms of books. But if anybody's interested in what's happening in science or math or engineering or physics or medicine, it's the journals. The
Mm-hmm.
journals are really, really, really cutting edge. And in my work as a journal editor, which is very, very rewarding, um, you know, there's nothing more current and up to date. But journals are tough to navigate
Sure.
because the results are new. They maybe haven't had time to percolate in the community, right? And different studies don't always agree. Textbooks tend to focus on settled questions, right? Or solve science. Like this is the best way to treat problem X, right? Or disease Y. Whereas journals are more sort of like like the first draft,
Mm-hmm.
right? Journals show current research, new ideas. So I always say to patients, and most people are pretty sophisticated, if you're interested in what doctors are reading or what we're actually thinking, like you can peek at our journals because a lot of our journals are,
Yeah.
you can read them free online, or at the very least, you can read the tables of contents and the abstracts free online. So like, I think that, as a GI doc, I belong to three or four of our national societies. So when you join the society, you get the journals in the mail, and when you crack the journal every month, like that's where the new information is. So I
Mm-hmm.
would just say to people, like, if you're really, really curious about where stuff is going, right? Don't wait for the news. Don't wait for a textbook. Just go online and look at the journals. That's
Mm-hmm.
kind of the where all the excitement is. But again, recognize it's going to be dense. I read some math and physics and space journals, and I'm really, really, really well versed in that. And a lot of that I have to really, really pay attention closely. So,
Mm-hmm.
it gets dense quickly.
Right. I
So,
will put the link to your website, Doug, and
oh yeah, thanks. That'd be
there's a
great.
link. There's a link there that ultimately goes to PubMed and the
Right,
hundreds of
right.
articles you
And
put it there. We'll also link to gastrointestinal endoscopy as well.
yeah,
So
and I'm at Douglas Adler, MD. On Twitter, I believe, or at Douglas G. Adler, MD. I can't even
got
remember my Twitter handle, but if you look for me on Twitter, I'm not hard to find. X, whatever
got
you
it.
want to call it.
Got it. Got it. No, we'll put links to all that. But yeah, it's an exciting area, and I really appreciate the time if you just walk us through it as you have. It's complicated, but again, you're touching on so many different therapeutic possibilities. It's exciting, and it's exactly what we like to profile on the show. So hats off to you. I look forward to continue to follow your work. Again, for everybody out there that's going to be listening to this episode across the various podcast networks or who will be watching on the YouTube channel. Again, you've been spending time with Dr. Douglas Adler, director at the Center for Advanced Therapeutic Endoscopy, Porter Adventist Hospital, as well as editor-in-chief, Gastrointestinal Endoscopy, doing really amazing work to not just improve the diagnosis and treatment of patients with various GI disorders, but ultimately usher in, as he says, this era of transluminal therapies. Doug, again, thank you for taking the time out of your schedule today to talk to us, to educate us on these themes. Thank you for everything you do for patients. And as we like to say on our show, thanks for helping to create a better tomorrow for millions of people out there via the type of research and work you've been doing. Really
Great.
great
Thanks for
story.
having me. I really appreciate it.
Great having you today.